global budget design and use in the United States. It's fairly limited, but there are some instructive lessons that we can draw from where hospital global budgets have been employed. And my colleague, Deepti Kanaganti, who's a senior consultant at Baylor Health, is going to give this presentation. Deepti recently wrote a report on hospital global budgets for the New Mexico legislature. So she's going to draw from that work. Two, we're going to hear from Bob Murray on a flexible global budget approach for possible use in Rhode Island. This is an approach that's a little bit different, but related to other hospital global budget models that have been employed elsewhere in the United States. Bob is president of Global Health Payment, LLC. He also served 17 years as the executive director of the Health Services Cost Review Commission in Maryland, which is the all-payer rate setting agency in that state. And then finally, we're going to hear about or hear from the perspective of a Maryland hospital that worked within hospital global budgets. Patrick Dooley is a director at the Berkeley Research Group, but he formerly served as a vice president at the University of Maryland Medical System. So we've got a great agenda for today and great speakers, and I hope you find this all instructive. Next slide, please. So I just want to give a little context for this work and why we're talking about hospital global budgets today. The Rhode Island Cost Trends Steering Committee has been working since, well, 2018 now on an effort to slow the growth of, or the rate of growth of healthcare spending in the state. And it decided that it wanted to focus on adoption of advanced value-based payment models, or VBP models, as one mechanism to help slow healthcare spending growth. And so it commissioned a value-based payment subcommittee that began meeting late last summer to examine how we might accelerate the movement away from fee-for-service payment models. And in that context, the value-based payment subcommittee has looked at a few different approaches to moving away from fee-for-service payment. Hospital global budgets is one. And the reason for looking at hospital global budgets is we know from data collected through the Cost Trends Project last year that nearly 40% of healthcare spending in the state goes to hospitals. And that's only considering facility services, because hospitals also increasingly employ professionals. And so you could see a good share of healthcare spending in the state is also for professional services. So this is why it makes sense to consider value-based payment models for hospitals, and why we're talking about hospital global budgets today. Next slide, please. I want to note that even before COVID-19, hospitals faced challenges due to changes in patient utilization, and in general across the United States. There's been a reduction in inpatient utilization, and there are constraints on price growth in Rhode Island. Then once COVID-19 hit, only federal relief payments helped keep some hospitals solvent. And then more recently, a surge in hospitalizations and real workforce problems have created additional challenges. So in this context, hospital global budgets can be supportive of hospitals by offering a few things, and this is going to be discussed much more by the presenters that will follow. They ensure steady, predictable financing. They give hospitals much greater flexibility in terms of their service offerings and allow them to match those service offerings with community needs. They can produce positive outcomes without hurting hospital finances, addressing the wrong pocket problem. And finally, they can control rates of growth in hospital spending and keep them at affordable levels. So, with that as an introduction, I want to hand things over to Deepti, who's going to give you some information about experience with hospital global budgets across the United States. Deepti?
Thank you, Michael. So this, just to start us off, what is a hospital global budget? So the definition here is in the dark blue text box. Global budgets are fixed prospective payment systems that are based on historical utilization and are adjusted annually based on changing demographics, market share, and service mix. So under the current hospital payment system, hospitals are paid fee for service. And under the fee for service system, hospitals are incentivized to deliver more services and notably higher margin services to maintain financial viability, since that is how they get revenue. Under the hospital global budget system, however, hospitals are received a set payment for a set of defined services that are determined prospectively. So this by nature encourages hospitals to reduce their utilization so that they can meet their budget. And budgets are modified on an annual basis to account for a number of factors, like we just mentioned, demographics, market share, and service mix. There are 4 states to date in the United States that have hospital or have had hospital global budgets. 3 of them still have them in place. New York has its Finger Lakes Hospital Experimental Payment Program that began in 1980 and continued until 87. New York moved to an all-payer DRG payment system, and as a result, it stopped its hospital global budget model in the late 80s. Maryland is probably most well known for its hospital global budget program that's run by the Health Services Cost Review Commission. It began with a focus on rural hospitals in 2010 and then was expanded to include 37 additional hospitals in 2014. Maryland is currently running its total cost of care model, which is its successor to its all-payer model, which is where the global budgets were most recognized. In Vermont, they started an all-payer ACO model with CMS, Medicaid, Blue Cross of Vermont, and OneCare, its statewide ACO. That began in 2017, is still continuing to date. And finally, Pennsylvania began its Pennsylvania Rural Health Model, which began in 2019. We'll now go through some different aspects of hospital global budgets in detail and talk about how each state has implemented their hospital global budget model. We do want to point out that each state has very unique circumstances and that impacts how they designed their model. If Rhode Island were to adopt hospital global budgets, it's likely to look different from all of these individual states and will likely draw from lessons learned from each of these states that have implemented the model so far. So we can start off with hospital participation, who is included in a hospital global budget. So you can see here, it's quite variable depending on the state. When New York implemented its model, it focused on 7 Rochester hospitals and 1 hospital outside of city limits. Maryland included all of its acute care hospitals, so that's roughly 40 to 50 hospitals. Pennsylvania focused on critical access and acute care hospitals in rural areas. So that was the targeted focus of Pennsylvania's model. And Vermont, its model is implemented through OneCare, its statewide ACO. And so their model includes 14 of the state hospitals that are across the state, some rural, some not, and Dartmouth-Hitchcock. In terms of which payers are participating, so Maryland is unique in that it has all payer rate setting authority and has had that since the 70s. So all payers are participating in its model, and that's inclusive of commercial payers, Medicaid, and Medicare. New York, Pennsylvania, and Vermont are including Medicaid, Medicare, and select commercial participation. So they have some, but not all commercial payers in the state participating in their global budget model. I will note here, Medicare often participates in these hospital global budget arrangements through arrangements with CMMI. And so that's how states have gotten Medicare to participate. In terms of how to distribute and monitor payments, so each state does this a bit differently, and we'll go through them one by one. In Maryland, hospitals are paid retrospectively on a fee-for-service basis. So the fee-for-service rates are set in a way to match the total global budget arrangement that was agreed upon prior to the start of the measurement year. Rates are then adjusted up and down during the year to ensure that hospitals are meeting the budget. The spending and utilization are monitored on a monthly basis, and hospitals are able to increase fee-for-service rates during the year if they're coming under budget, or decrease rates if they're starting to go over budget. There are there are limits to the sizes of adjustments that hospitals can make without receiving a pre-approval from the Health Services Commission. And hospitals are penalized if their utilization is greater or less than 0.5% of their projected utilization. In New York, hospitals are receiving weekly prospective payments. So that's a difference right off the bat from Maryland. There is reconciliation that occurs on a monthly basis, but that is limited to variable costs only. Pennsylvania, there are two different payment models depending on if it's coming from CMS or if it's coming from the commercial payers. The CMS, similar to New York, does prospective payments, but it occurs on a bi-weekly basis. It's interesting, so in Pennsylvania, CMS is reconciling budgets to actual costs only for critical access hospitals. So we call this not a quote unquote true hospital global budget because of the reconciliation that occurs, but it is limited to critical access hospitals, not acute care hospitals. Commercial payments do make fee-for-service payments that, similar to Maryland, are based off of the total budget, and that is also reconciled. Vermont, Blue Cross and Medicaid are making fixed prospective per member per month payments. Medicaid does not reconcile payments, and it's not listed here on the slide, but Medicaid pays a certain portion through these prospective PMPM payments, and the other remainder of the budget is paid on a fee-for-service basis. For Medicare, they pay on a fee-for-service basis, and they reconcile payments based on fee-for-service equivalent spending. The reconciliation, similar to other states, is limited, so it's the risk corridor here is 3 to 4 percentage points of the predetermined budget. Now moving on to how budgets are established and updated. So New York, Maryland, and Pennsylvania are all establishing their budgets based on historical inpatient and outpatient revenue. Maryland used all payer revenue to establish its budgets, whereas Pennsylvania uses payer-specific revenue for each of the budgets. All of the budgets are adjusted for future years, and how that calculation is done varies depending on the state and is pretty advanced. But it does take into factors such as inflation, demographic and market share adjustments. Some states have a quality performance component to it, and also an adjustment for uncompensated care. And finally, additional supports. Some states have elected to include additional components to their hospital global budget programs. So for example, in Maryland, they have additional programming and funding, such as through their Care Redesign program, which was implemented under the total cost of care arrangement. And that is funding designed specifically to improve coordination with community-based providers. In New York, they had a separate regional contingency fund, and that was primarily to support changes in budgets due to changes in case mix, as well as some medical infrastructure technology support. And that had to be regulated by initially the Certificate of Need process. Now going into some findings from each state experience, and we'll go in chronological order here. So New York, after it implemented its model, it found reduced growth in hospital operating revenues and expenses. They also realized improvement in net margins. What's interesting to note is there is potential for New York's model to have yielded stronger results. And this is partially twofold. One is that physicians were still paid on a fee-for-service basis throughout the model. And so while hospitals were incentivized to change their utilization patterns, physicians were not. And so expanding the model to include physicians may have yielded stronger benefits. And that's what we see in some of the later iterations of Maryland's model. In Maryland, Medicare and commercial realized reduced hospital spending. Medicare's hospital spending was reduced by 4%, and they attributed this largely due to slower growth in ED and outpatient spending. They also realized reduced total expenditures for Medicare, as well as reduced admissions for Medicare and for commercial. Here, Medicare hospital admissions declined by 7%, and unfortunately, on the hospital admission side, there was not a corresponding decrease in spending. And finally, Maryland did find reduced ED visits for Medicaid and for commercial. In Vermont, Vermont realized decreased hospital-based utilization and expenditures for Medicare in the second year of their model. And they think it was decreased utilization leading to decreased expenditures, which is pretty intuitive. They also found that the majority of hospital payments are still paid on a fee-for-service basis. And so this is quite challenging, similar to the New York model where physicians were not included. It's much harder for hospitals to be able to adjust their utilization patterns if their physicians are not incentivized to do the same. In Vermont, having only a portion of the revenue come through a hospital global budget makes it quite challenging for hospitals to use the payment mechanism as a steady funding source for reorienting how they deliver care. So between 2020 and 2022, they estimate that 14 to 15% of net patient revenue is coming from global budgets, which is quite small. So that's an important factor to consider is how much of a hospital's revenue is coming through this specific payment model. And finally, in Vermont, there are some urban hospitals in Vermont, but also there's a lot of smaller rural hospitals that are scattered throughout the state. And an evaluation found that these hospitals were reluctant to participate because of the financial risks that could be associated with the hospital global budget. And finally, Pennsylvania. So there's limited effectiveness to assess the little data to assess the effectiveness of Pennsylvania's model. So Pennsylvania's model was implemented in 2019, and then COVID happened in 2020. So there's really only 1 year of pre-COVID data, and that's the first year of model implementation. So we're hoping to have more data as time progresses to be able to evaluate their model a bit more. The one thing that is pretty apparent from the outset is that there's a lot of different types of hospitals that are participating. So critical access hospitals, system-owned hospitals, and independent hospitals. So this is pretty important because it shows the allure of hospital global budgets across the spectrum of types of hospitals. In terms of challenges with hospital global budgets, so the first one we kind of just addressed through the rural hospitals in Vermont. So hospitals and or payers can be reluctant to engage in global budgets. And there's two components here. It could be due to the financial risk of a global budget arrangement, or it could be due to just the technical challenges of implementing a model. So in terms of the financial risks, states have implemented some mitigation strategies to try and reduce the risk associated with global budgets. That could be something as purchasing reinsurance or defining parameters for how to modify budgets to account for a number of various scenarios that may or may not occur. In terms of the technical challenges, it's helpful here to have a specific state agency that's tasked with implementing and supporting the model. So Maryland had its HSCRC, Pennsylvania implemented a new, established a new agency designed to help with global budget implementation for rural hospitals. We also have several states that have implemented models already. So learning from them and trying to anticipate some of the challenges can help here. Global budgets could also lead to stinting of needed care or shifting care, especially to settings that are not captured under the global budget. So here it's really important to establish parameters to monitor care utilization and spending in non-covered settings. So for example, if the global budget is focused on hospital, inpatient, and outpatient, what is happening under specialty care scenarios? It could also lead to changes in price of services, which is something else that states should be wary of monitoring. And in addition to monitoring, states could also expand global budgets to include professional services of hospital employed physicians. And they can also implement complementary payment arrangements for other settings to discourage excess utilization or to try and prevent against stinting in such care settings. And finally, if global budgets are not designed properly, they can reinforce structures and inequities that we don't want to enforce. So for example, if a hospital has been historically providing substandard care for low income, non-English speaking, or Black, Indigenous people of color communities, that could either be due to not having sufficient resources or another factor. If we don't properly account for that, then the global budget will continue to reinforce that type of care. So states should be mindful of how they're setting their budgets to prevent against this. And they could also supplement global budgets with supplemental payments similar to what we saw in Maryland in order to fund infrastructure and population health activities that could help in this regard. And finally, now just talking through some key factors for success in what other states have done. One is pretty apparent. Hospital global budgets are really dependent on whether or not there is support from hospitals, non-hospital providers, and payers. Without widespread support and participation, global budgets are pretty hard to be successful. Again, because hospitals would not be receiving a sufficient amount of their revenue through this payment model. There also needs to be a robust methodology for developing and adjusting budgets. So there's multiple formulas that other states have used for setting the budgets and updating the budgets, but it's important to ensure that the budgets are robust enough that they can provide funding to sustain hospitals and also account for things like clinical innovation and capital upgrades. But they also need to be mindful so as not to incentivize unnecessary utilization. There also needs to be strong HIT infrastructure and population health initiatives. And this is really helpful for hospitals to determine how to properly monitor, analyze, and adjust their utilization and spending patterns in order to meet their budget. This should definitely include limiting the analysis to hospital systems, but it can also include analyses of non-hospital providers, and that really helps with that stinting challenge that we just talked about. This is particularly, I won't say easy to do, but easier to do with hospital systems that have common EHR records, but that is something that's often out of the control of a state agency. And finally, having state government support to help address the technical complexity around global budgets is quite helpful. This helps, one, develop budgets in a way that's consistent across different hospitals. It provides a system for helping provide technical assistance for hospitals that are interested, and also for having an agency update budgets over time as well. So that is a quick Hospital Budgets 101 to help us prepare for hearing from our next presenter, Bob, who will talk about a flexible global budget approach for possible use in Rhode Island.
Hi, everyone. My name is Bob Murray. As Deepti and Michael said, I was the Executive Director of the Health Services Cost Review Commission during a period where the system was under more or less a fee-for-service structure, but then we transitioned to use of global budgets for rural hospitals. I'll talk a little bit about that. But Deepti, why don't you advance the slides and we'll get into the discussion. As Michael and Deepti mentioned, this approach is a little different than what has been employed previously. It's based on Maryland's experience, but it is intended to really avoid the complexity and excessive detail that is implicit in the Maryland system. I mean, the Maryland system has been in operation for over 35 years, and it's also been layered on with multiple adjustments and various issues. But the complexity itself is a function of its original statute and also the requirements of the statute and the requirements of the waiver. So we try to avoid that in the model that we're going to present here. I should mention also it's a function of, or it's informed by the experience in Rochester and the Finger Lakes. As Deepti mentioned, there was a very successful global budget implementation in the 1980s in those regions. And a colleague of mine, Jack Cook, was the chief financial consultant to the Rochester model. And so this approach employs some of the characteristics of that model as well. Maybe the next point. Just a key point here is that the original global budgets in Maryland were what I call 100% fixed. That is, once they were projected to the performance year for the demographic factors and then updated for inflation factors, they didn't vary during the course of the year. So if a hospital had additional utilization that it experienced, it basically did not get additional revenue, and it would generate losses under that type of model. Whereas this approach would employ what I refer to as flexible global budgets, where the budgets would flex on the basis of a hospital's variable costs, up or down with volume changes. So it's a little bit less rigid, more flexible, reduces hospitals' financial risk, and I think it has some other advantages as well. If I go to the next slide. Mention very quickly a little bit about the hospital experimental payment program in Rochester. As Deepti said before, it's 9 hospitals. It was about $1 billion in revenue, 800,000 residents in a fairly self-contained region in the Rochester area. It was developed with very, very strong support by local business. Business groups had a very significant role in trying to design the system and also promote the system, along with Blue Cross, which Blue Cross was a dominant payer in the area. It did receive an all-payer waiver, which is similar to the Maryland all-payer waiver. And it also had the participation of the Medicaid program in New York as well. So it was an all-payer model that was implemented. Some of the characteristics, it was very formulaic. You had certain rules and formulas that were applied. Everyone knew what the formulas were. They created basic incentives. So it was a rule-based system. People understood what the rules and the incentives were. And it was also very predictable because it was derived from historical costs that the hospitals generated. They were trended forward and adjusted, as we discussed before, for things like demographic changes in the patient service area, and then also inflation over time. It was basically administered by a staff of 5 or 6 people. So because it was formulaic and controlled budgets at an aggregate level, it didn't require the complexity that a system like Maryland currently has. And so as a result, it was more easily administered. As mentioned before, it had very strong incentives for the hospitals to reduce their costs, because if they did so under a fixed budget or a slightly variable budget, they could generate profits. And they were rewarded for reducing waste and then coordinating overall process of providing care to their patients. Very, very supportive of the priorities of population health. The results, as we've talked about, much lower expenditure trends, but also what it did, because of the predictability, it improved the financial performance of the hospitals in the state. The next chart is pulled from an article in 1993 in Health Affairs. It just provides kind of an overview of the HEP evaluation. You can see here that Rochester did, during the period of the program, did experience reduced spending relative to the national average. And actually, during those first 5 years, if we could move to the next point, expenditures rose only 46% versus 52% in what was considered to be an extremely tight all-payer rate-setting system in the rest of New York. So it outperformed one of the most successful cost containment programs in the United States, the New York all-payer system, and it beat the US by 4% per year compounded basis. It's all contributed to very stable premium growth during this period. You can see that the success sort of waned after 1987, as Deepti said. That's when Rochester gave up the system. And they gave up the system because that was about the time that Medicare implemented PPS, and the hospitals in Rochester realized that PPS at that time was more generous than Medicare payments in the state. And so they opted to give up their demonstration and move to the national system. That excessive generosity, of course, didn't continue over time. And so I think many people in Rochester were very upset that the program was terminated. So if we could move to the next slide. You can see here, and you can just click through these, Deepti. You can see this is also from an article by Jim Block in GM in 1987. You see the results from the standpoint of profitability and cash flow. The Rochester hospitals improved their profitability and cash flow relative to other hospitals in New York and New York City under a very stringent rate setting system, very complicated and detailed rate setting system, I might add. And in addition, then, of course, we've discussed this, that under the incentives of the global budget, hospitals in Rochester reduced utilization over time. So you really got the best of many different worlds and objectives under this type of system. We'll move to the next slide. So as I said, the proposed approach today borrows from concepts from both Maryland and Rochester. And the Maryland system is very complex, as I've emphasized, and it was largely because the statute required that individual rates be regulated and that they relate to cost, and they're not to be cost shifting from one revenue center to another. The Medicare waiver also imposed certain restrictions on the state. And so as a result, the Maryland system developed this very, very detailed and complex individual rate center system across some 70 different centers. So you have compliance at a very detailed level. And as I mentioned before, over time, there's a tendency to make adjustments and changes, and the system became even more complex over time. So we're not recommending that type of a program. We're recommending a program that's more like the HEP, that regulates revenues at an aggregate level and is more formula driven. As I said, it's a rule-based system, and people understand the rules. It's more predictable. It has incentives to improve affordability and efficiency. And I might add, in Rochester, there was a very, very strong emphasis on health planning during that period of time. So you could coordinate the planning process and the CON with the priorities of population health and the HEP, and augment the positive results from that system. In Maryland, in 2008, when I was at the commission, the genesis of the global budgets was in the period 2001, 2002 through 2007, we experienced tremendous growth in hospital utilization. And that was because we were in danger of losing our waiver, and we ratcheted down our rate increases during that period of time to try to continue to survive under our waiver test. But that induced hospitals to increase the services that they provided. We saw huge increases in volume during that period of time. So we moved to global budgets. Like the global budgets in Rochester, they were adjusted for demographic changes, largely growth and aging the population, which you can use historical data and then project moving forward. But they were 100% fixed global budgets. So you had that dynamic where if you got a change in utilization during the year, the revenue the hospital received didn't change. So that put especially smaller hospitals under a high degree of financial risk. And And it created also potential for some other negative things that I'll mention in a few minutes. But one of the things that was okay about this approach was that small rural hospitals, at least the ones that we applied it to, had cost structures were primarily fixed. They were 80 to 90% fixed because they had capital, depreciation, considerable standby costs. So applying a largely fixed global budget to these rural hospitals made more economic sense and created less disruption. I should mention the budget control system under this approach and under the current Maryland approach it's what I would call a price times quantity equals the global budget approach. Where during the course of the year, as volumes go up or down, the hospital and the rate setting agency then will vary the price. As volumes go down, the prices go up. And as volume go up, the prices go down. So the P times Q equals the global budget. That's the mechanism that ensured compliance in this type of structure. Go to the next slide. In 2014, after I left the commission, in the new demonstration, the Maryland rate setting system, and along with CMMI, decided that the fixed global budget system should be applied to all hospitals, which surprised me because applying a fixed global budget to a hospital like Johns Hopkins or University of Maryland, it just seemed like it created potential problems because their cost structures are very different and they have different requirements. We found that 100%, the experience that I recognized when I was there, when I was observing this, is that this type of system tended to penalize lower cost, higher quality hospitals when payers like Kaiser or Care First, which had a medical home program, or ACOs tried to shift volume from a high cost hospital to a lower cost hospital. That lower cost hospital didn't want the patients, and they resisted those sorts of attempts, even though that they were higher value and probably should have been rewarded with that additional volume. But under fixed global budgets, they were basically disadvantaged because they didn't receive more revenue. The program also tended to provide disproportionately strong incentives for hospitals to sort of avoid volumes. We heard many circumstances where hospitals didn't renew contracts for specialists or even fired specialists, attempting to shed volume to other facilities. And there's evidence of increase of waiting times, particularly for emergency room care. In Europe and also in Canada, there was evidence that global budgets that were applied there, which were also fixed, contributed to much increase in waiting times for elective procedures. So big fixed budgets tend to impede this free flow of patients across hospitals. And as I said, this type of thing is what led myself and my colleague Jack Cook to propose this alternative flexible global budget, because we thought that it would be more accommodating of patient volume change, and also accommodating of new technology for academic medical centers. DT, if you could move forward on that. And so this experience also just kind of mirrors what's available in the literature on the experience of the global budgets in Canada and also in Europe. So I think it may not be the best model, a fixed global budget for Rhode Island. So let's move to a further discussion on flexible global budgets. First, just wanted to kind of talk about, fee-for-service incentivizes volume growth, but why is that? We basically we've kind of taken this for granted, but we haven't dug into the details of hospitals' cost structures and why hospitals have an incentive to increase volumes. If you can move to the next bullet point, it's really a function of hospital cost structures. We did a series of cost studies in Maryland. New Jersey also did cost studies. And the results of these studies tended to show that for larger hospitals, hospital proportion of fixed versus variable costs are roughly 50-50. So you have, fixed costs, overhead, standby, capital depreciation, and then variable costs are just obviously supplies, things that staff, some staffing changes vary with volume. So anything that varies with volume change. But under fee-for-service system, when a hospital gets paid for each new incremental case, they get 100 cents on the dollar for every new service. But the cost to produce that new service, if you agree with the analysis of the cost studies, is only 50 cents on the dollar. So there's an excess of marginal or variable revenue over variable costs. And this dynamic also causes hospitals to lose money when volumes decline. So that the hospitals in general will resist efforts like ACOs, other population-based mechanisms to reduce volumes because it hurts them financially. Now, in contrast, 100% fixed global budgets, as I said, you get no additional revenue for any volume growth. And likewise, the global budgets will reward, I think, excessively 100 cents on the dollar for any volume reductions. So this structure creates what I think are disproportionately strong incentives to reduce volume and may encourage hospitals to stint on care, eliminate services, and things that I've mentioned, things that were determined to take place in settings like Europe and also Canada, where they implemented fixed budgets, and I think to a certain extent also in Maryland. Now, flexible global budgets work similar, but without that extreme rigidity. And so move to the next slide. While fixed global budgets, second, let's see, I'm gonna have to adjust this, do not increase or decrease the amount of revenue the hospital receives, flexible global budgets will, as I say, flex marginally up or down over time. If we can move to the next slide. For instance, now, if you have a structure where hospital costs are 50% variable, a flexible global budget will provide additional revenue to cover these new variable costs in the case of volume increase. So it wouldn't be completely capped, and it would recognize that hospitals that are receiving additional volume because they're high value hospitals, say shifts from an HMO or an ACO, they'll need additional revenue to cover these variable costs with these new volumes. Now, likewise, a hospital that has a volume decrease, the flexible global budget would flex down slightly, but it would still guarantee that hospital sufficient revenue to cover its fixed costs as volumes decline over time. So the point of this approach is that the flexible global budgets removes that excess of variable revenue over variable costs that you get under a fee-for-service structure, but still would provide enough revenue to cover fixed costs and still provides an overall incentive to reduce unnecessary utilization, or at least not unnecessarily increase utilization, which hospitals under fee-for-service have an incentive to do currently. Now, operational features, the system like this could be operated like it was in Rochester. The Rochester Area Hospital Corporation was a quasi-public entity, or you could have an independent state entity like the HSCRC or the Green Mountain Care Board in Vermont to oversee it. The budgets are set and enforced at the aggregate level as they would be in Rochester, so you don't have that excess complexity. It would grandfather in hospitals' historical rate base and revenues. So it's much more easy for these hospitals to manage to the constraints over time. It also would retain the current hospital and claims payment system. So you wouldn't have to completely revamp payment, require all payers to pay on a per capita basis, which has certain complexities and also certain legal challenges associated with it, particularly with regard to the self-funded accounts. And then in subsequent years, you get adjustments for changes in demographics, as I said, inflation, and various other adjustments that could be applied. One of the other advantages, I know this took place in Rochester, it definitely took place in Maryland, is that when you have an oversight agency, they can adjust to changes in the environment as a result of like the pandemic or other natural disasters, and adjust hospital budgets accordingly and create additional level of stability in the system. Now, the budget that I would anticipate would include hospital inpatient, outpatient services, but it also can include employed physician services and other non-hospital services or home health, long-term care, subacute, so that a larger budget could control more services on a consistent incentive basis, and even to create situations where you'd have payers that could participate in gain share arrangements with hospitals to try to align the incentives, gain share with physicians, I should say, to align the incentives of the physician community with the incentives that are faced by the global budgets. Now, the global budgets have the following advantages. Basically, money flows more consistently with a patient from one hospital to another. They don't restrict payer, patient, physician choice, as we found it could occur in the case of a fixed global budgets. DT, if you could scroll through these points. The model still removes incentives to increase volumes unnecessarily. It provides more predictable revenues to hospitals, covering fixed costs when volumes decline, and is more commensurate or supportive of population health. The model also would apply to all hospitals and all payers, including Medicare and Medicaid. This is the type of thing that could be negotiated with CMMI, as they've done in Vermont and also in Pennsylvania. So you want all payers in this model. And it would support a cost growth target that the state overall might have, as states have formulated through their total cost of care growth benchmarking system, so that you could align the inflation updates to the global budget with the overall state growth or goals with regard to payment growth and expenditure growth. Now, this is a very high level presentation, so I was asked not to go into tremendous detail, but very quickly talk about how this might be developed for one hospital. Just as in Maryland, where the rate setting agency would adjust price as volumes change during a performance year to hit the target budget, this model would be similar. The approach, though, would be more flexible than a fixed global budget or a fixed PMPM payment structure by payer, which is more akin to the model that was developed for Rochester. Although, as Deepti said, there were adjustments for variable costs in the Rochester model. So that more mirrors the approach that I'm recommending today. So step one is that the state would obtain data from all hospitals with regard to their patient revenue in some base year, or it could be an average of multiple base years. So in this case, I have a hospital that has $200 million in gross patient revenue and $100 million in net patient revenue. I have just kind of rough amounts by payer, and showing also the payer discounts from gross to net on that third line down. If you scroll forward, Deepti. And so the idea is to operate the system in this more aggregate way. The state would fix the discounts between the gross revenue payments and the net revenue payments by each payer. This is because under this mechanism, then if the state can control the charge change for each hospital, that in turn adjusts the net payments of each payer. And you can have a situation where the prices that are paid by each payer times the quantity of volume that is delivered would equal the global budget. It's at a very aggregate level. And as I said, you scroll right through the next slide, this fixing the relationship allows the implementation of this global budget model. Yeah, if we can go to the next slide. Then the step three is then you calculate the aggregate measure of volume. In this case, I'm suggesting using a concept called case mix adjusted discharges, where a hospital would report on its total discharges for inpatient, create a measure called case mix adjusted by discharges by multiplying its case mix index times the number of discharges. There's an equivalent structure that would be used for quantifying outpatient utilization. But in this case, I've simplified it. I said the hospital had 8,649 discharges, had a case mix of 0.925. So it has 8,000 case mix adjusted discharges. That's the quantity or the volume statistic. The step four then you would project that performance year volumes, adjusting forward by demographic adjustment, and then inflate these prices. And there are two prices that I mentioned: gross patient revenue per adjusted case and net patient revenue per adjusted case. And if you scroll through the next set of animations, you'll see these numbers. The the case mix adjusted cases are updated by the demographic adjustment for aging and population growth. That's 1.015. So you now have a projected volume for the performance year. Then you take the price statistics that we've created, which is $25,000 per adjusted admission for gross patient revenue and $12,500 for net patient revenue, and you inflate those to the performance year, and you get price statistics: $25,625 for gross patient revenue per adjusted case, and $12,813 per net patient revenue per adjusted case. And you multiply the new projected volumes times the projected prices, and you have a new budget for the performance year of $208 million for gross patient and $104 million for net patient revenue. We can move forward to the next slide. During the course of the year, of course, volumes will fluctuate. And so the idea of the flexible global budget, unlike a fixed global budget, is that a fixed global budget, you have a 1% increase in volumes, it would require a 1% decrease in prices to meet the fixed global budget. But under the proposed approach, well, same thing for a decrease in volume. But under the proposed approach, you'd monitor the changes over time, but it's moderated by this variable cost factor. So that if you're assuming that costs are 50% variable, a 1% increase in volume would result in a 0.5% decrease in price. That's the 1% times the 50% variable cost factor equals 0.5% price change. And so it allows the hospital to fund any sort of variable costs associated with new volume. But unlike the fee-for-service system, we've now removed that excess of variable revenue over variable costs for incremental volumes. So you've removed that incentive to unnecessarily increase volumes. Now, likewise, for a 1% decrease in volume, you get the same sort of adjustment, and that adjustment allows for the payments to cover the hospital's fixed costs in the event of a volume decline. If you could scroll through the next points, and we'll move to the next slide. So in summary, hospital global budgets can provide more predictable revenues for hospitals and stability. I should mention also, they do have the feature that costs more follow patients, so you have less financial risk that are applied to the hospital, particularly small hospitals where that's a big problem. Flexible global budgets provide better coverage of fixed costs if volumes decline, so they protect hospitals on the downside. The payments are not prospective in the sense that they are paid on a PMPM basis. They retain hospitals and payer claims payment systems, and it's sort of a system that overlays the adjustments to the whole system to get compliance with the global budget fairly transparent, in a transparent way. As a result of this, it's more compatible with the self-funded accounts, which have restrictions on how they can pay hospitals. They can't pay on the basis of a PMPM. Flexible budget models are also very compatible with population-based approaches in that they align the incentives of hospitals with entities like ACOs. And there are adjustments and various modifications. I won't go into those now, but perhaps when we have a Q&A and discussion, I can talk a little bit more about that. And as I said, this is just meant to be a very high-level discussion, and I'm happy to circle back, go into more detail, and certainly answer all your questions. So let me stop there. And Michael, if it's appropriate, I could introduce Patrick Dooley, who,
please do,
as a friend and colleague of mine. I knew Patrick when I was at the HSCRC. He was chief of staff to Pete Hammond, who was very, very progressive and influential committee member, one of the health committees in Annapolis. Patrick then went on to work for the University of Maryland, where he's vice president of population health. He was very involved in many of the work groups, the policy work groups of the HSCRC. And then more recently went to work for Berkeley Research Group as a senior director for their economic and clinical research division. And just has a really good perspective, and has worked in various fields, largely what I would call a policy perspective, which I think is very important. So I'll turn it over to Patrick to introduce himself. And as I said, I'll be around to answer any questions. Thank you very much.
Great, thanks, Bob. I appreciate the introduction. So as Bob indicated, I kind of spent a number of years working for the state legislature and the state health department, and so kind of had a policy, regulatory, political type background, but then really wanted to better understand kind of the operational side of things. And so in 2014, I took a position as the senior director and then subsequently the vice president of population health for the University of Maryland medical system. And so in that role, my job was to coordinate with all of the hospitals across the health system to really stand up population health type programs. So 2014 was the first year that the global budgets have been applied kind of statewide to all of the hospitals. And so really focusing with the hospitals around, transitional care programs, high risk clinics, community health type programs. And so kind of standing those up in collaboration with colleagues across the system. The other thing that I was tasked with is really standing up the University of Maryland Medical System's clinically integrated network. And so we created a network of primary care physicians, almost 400 of them, only about a quarter of which were employed by the medical system. And then took that primary care network and went to payers, whether they be commercial, Medicaid, Medicare Advantage, or we also did a Medicare shared savings program for the fee-for-service population. And so created these ACO arrangements and then ended up managing about 150,000 lives across this network. We then also, as you can imagine, stood up various clinical programs to better manage the beneficiaries that we had these contracts with. And so ambulatory case management programs, pharmacy, social work, data analytics, kind of a whole host of things in order to better understand the population and what was happening there. So what I thought I could do today is just share kind of some insights from my point of view about things that work well with the global budgets, some of the challenges around them, and then maybe some key learnings as you all are focusing on this. And I will say these are informed both from kind of my work on the policy side, as well as just kind of on the day-to-day healthcare delivery. I will say having been on kind of the operational side, I would say that I'm better at the policy now, having been there, because it's one thing to put down a policy in writing. It's another thing to operationalize it kind of on the ground when you have to make it work. So with that, some of the benefits for the global budgets, and Bob touched on this, is it provides a better opportunity for alignment between the hospitals and payers. Now, I don't want to oversell this point and say it's all of a sudden, kumbaya between the payers and the hospitals, but it does align the incentives in a far better way than under a fee-for-service model. It did allow the promotion of investments in programs to keep people healthy and out of the hospitals. So since the incentives were now kind of flipped on their head to where you don't drive volume to drive margin, instead you need to keep people healthy and out of the hospital, and that's in fact how you drive your margin. It kind of flipped the investments that some of the hospitals were making. And so investing in things like high-risk clinics for high-risk beneficiaries, transitional care programs to keep people out of the hospital, not only just for the 30-day window, but even beyond, community case management programs with community health workers, mobile integrated health using paramedics and EMTs, kind of a whole host of things that wouldn't normally be invested in by hospitals under a fee-for-service system. All of a sudden now there were all the financial incentives to invest in those types of things. There was also a focus on avoidable utilization to the extent maybe not before. So rather than just having that diabetic continue to come in because their blood sugar was not doing well and just go ahead and admit them over and over, instead the conversation was, how can we better manage the diabetic population? How can we better manage the CHF and COPD population? That if there was some sort of an ambulatory relationship with a primary care provider or specialist, those individuals may not need hospital care and may not ultimately need to be admitted. And so again, it shifted the focus to no longer let's just go ahead and admit those individuals, but let's make sure there are better systems of care in place so that those individuals may not actually need a hospital level of care. It did also promote kind of innovative delivery models. So in Maryland, we have created what are called freestanding medical facilities. And so you can think of these as kind of a reimagining of an acute care facility. And so instead of having all the things that an acute care hospital has, it's basically, you would have an emergency department, some observation beds, and then kind of outpatient and specialty clinics kind of to a much greater extent. And so this model has successfully been implemented for a few of the hospitals in Maryland, basically taking an old acute care hospital that didn't really need all the services that it previously provided, with all of the fixed costs and other things that Bob specifically mentioned, and instead pivot more towards a community-based clinic that still has many of the emergency services and other things that that community may potentially need. The other thing that the hospital, that the global budgets does provide is if the hospitals can be more efficient in their cost structure, they still retain those funds. And so it does promote that type of thing rather than under the fee-for-service model, particularly in Maryland with the HSCRC, where hospital costs go up and they then go to the commission and ask for additional rate updates to cover those costs. Instead, there is kind of at least a theoretical benefit to being more cost efficient under the global budgets. Now, that all being said, there are some challenges that we've experienced in Maryland, and many of these challenges I think are addressable either by the model that Bob outlined or other policy considerations that could be considered. So the first is, if you don't continuously, or at least annually or some cadence, rebase or relook at the global budgets, it can lock in inherent inefficiencies. So you need to make sure that you're balancing whatever you put in place with still aligning incentives so that the hospitals are adequately incented to still reduce their cost structure when necessary and don't just kind of retain costs within the system itself. If you don't do that, you can kind of trap revenue or expense within the system. So you may have hospitals that have greatly reduced their volume, but if you don't rebase their global budgets, then all of that revenue and expense is just locked into those specific hospitals. And what that does is, in a cost-constrained system, then what you're really doing is limiting the investments that you can have either in community services or other hospitals that may have in fact seen an increase in the volume. And so you need to account for that in whatever global budget system you create. Maryland's system, and this is unique to Maryland and the way the global budget system works, actually makes value-based contracts like total cost of care, ACOs, difficult to manage and be successful in. And the issue there is, as Bob articulated, as volumes decrease, the price goes up so that the overall global budget remains the same. So what that can functionally do for ACO type agreements is you can do all the right things, such as reducing avoidable admissions, reducing ED visits per thousand, reducing length of stay, all of the things that in other parts of the country ACOs do, and then they successfully achieve shared savings. In Maryland, the challenge is, as you do those things, the price per admission or price per ED visit just goes up. And so when I used to run some of these ACO agreements, it was very challenging because although we would successfully be reducing utilization, the cost would still go up. And so you need to kind of account for that within the global budget so that there's a win not only from the hospital side to maintain a more stable revenue base, but also for the providers out in the community, and particularly the insurers and who they represent, which is businesses and others. And so you need to make sure that there is kind of an accountability and not only maintain the global budgets, but have that feedback loop back to the plans and others so that everyone wins. There is also the challenge that Bob highlighted with the academic medical centers, and that they have very specialized clinical programs. They also have teaching programs. And so how do you account for those types of services while at the same time trying to reduce unnecessary volume? You know, academic medical centers are going to have a certain amount of extra things that are provided because they are teaching the future providers. And so how do you kind of adequately account for what may be seen as unnecessary volume, while at the same time those programs have to have a certain amount of volume across all of those clinical programs in order to continue to have their accreditation, attract students, attract teaching talent, and other things like that. And so the academic medical centers in Maryland have been treated largely the same as the community hospitals, but that has been a source of challenge. The other thing that Maryland has moved forward with, but is still a work in progress, is how do you align those non-hospital providers? So the care redesign programs were something that were specifically mentioned to try to align non-hospital providers, whether they be the employed physicians of the hospital, skilled nursing facilities, home health providers, primary care, et cetera. But the challenge is, how do you successfully do that? So just to give an example, the hospitals are all held to a total cost of care test, not only for their global budgets, but for a certain population that is attributed to them. And if you looked at post-acute spend, you might say, wow, we really need to reduce the length of stay at skilled nursing facilities. But if you're that skilled nursing facility, there isn't any financial incentive to reduce the length of stay because they're still paid kind of on that per diem type basis. And so there needs to be more work to try to align the incentives across the continuum. One of the things that's been very helpful is the launch of the Maryland Primary Care Program in Maryland. So it's modeled on the Comprehensive Primary Care Plus model that CMMI had previously rolled out. And essentially what it does is it provides additional fees, which have to be used for clinical infrastructure for primary care practices to manage Medicare beneficiaries. And those providers are then held accountable for not only the cost of care, but particularly the utilization. And what this really does is it then aligns the primary care providers with now the necessary infrastructure to collaborate with the hospitals to reduce that unnecessary utilization in a way that wasn't previously available. And so while there is certainly more work that needs to be done to continue to align those non-hospital providers so that the incentives are aligned across the care continuum, Maryland is trying to proceed in a thoughtful way in order to do that. So just kind of some key learnings based on the 7 years or so that Maryland has been in this. So one is, don't underestimate the culture change that is necessary here. And it takes a lot of time. So, I have yet to meet a hospital CEO that became a CEO with dreams of closing down units, stopping certain service lines, closing down their hospital and transitioning to a freestanding medical facility. That's not the kind of culture that they've worked in, and understandably so. And so don't underestimate the kind of culture change that needs to occur, not only with senior executives, but frontline staff and others, that the way they previously practiced medicine and practiced business now needs to kind of shift a little bit and think about things differently. And so don't underestimate kind of the education that needs to occur, and that it just occurs over time. One of the things that we continue to struggle with sometimes in Maryland is this concept of good volume. So under the global budgets, you're provided incentives to reduce unnecessary utilization, while at the same time, you want to make sure that you still have a high functioning and high quality, orthopedics program, cardiac program, and some of those others that even if you're able to reduce all unnecessary utilization, you're still going to want high performing programs in those. And so how do you kind of balance not only the competing priorities, but also the competing messaging that can put out, in that we want to keep individuals out of the hospital, except for these specific service lines for these specific things. And so just thinking through kind of how you message that and how you consistently do it over time. The other thing is, don't just assume that because the payment model has changed that everyone understands how that works or why all of a sudden things need to change. So again, just reinforcing that consistent education. And again, that's not only for senior leadership, but really down through all of the staff. One of the hospitals in Maryland that was one of the rural hospitals that Bob talked about earlier actually had an education program for every single employee of the hospital, from the front desk to the CEO, when their new policy went into place, just to educate them and make them aware of what was going on. The other thing to just consider is to leverage macro policy tools. So, the hospitals can only do so much on their own. And so as you think about kind of managing the total cost of care and moving towards global budgets, how do you help the hospitals succeed? How do you think about things like school-based health centers, housing policy that the state has in place, transportation policy the state has in place? One of the things that Maryland has tried to do is to create these kind of statewide quality measures that are going to be measured around diabetes, opioids, and other things like that. And there are conversations ongoing with state policymakers about how do you use other levers of state policy to kind of align the incentives, not only just for the hospitals, but the primary care providers, the specialists, non-clinical providers as well, so that everyone is kind of rowing in the same direction and focusing on the same things. The other thing I would say, and Bob kind of mentioned this, is to keep it simple. So there is a lot of complexity to the Maryland system for many of the reasons that Bob outlined. And what you want to try to do to the extent possible is make it as clear as you can that if you do this, then you get that. And the problem is it's not always a clear line of sight for some of these regulatory programs that says, if I'm able to reduce this specific utilization or improve this specific quality measure, this is the financial or other outcome that is going to be achieved. And so to the extent possible that you can align that and make sure that it's as clear a rationale as possible and clear cause and effect, that will be helpful not only in gaining engagement, but also being able to articulate the purpose to the providers and others. And the other thing I'll say is don't forget the public opinion on this one. And I mean that in the sense that all of the regulatory structure and the policies that were put in place in Maryland incentivize the hospitals to do things like reduce services that weren't necessary, convert to freestanding medical facilities, do those types of things. But as you can imagine, if any community that hears that a service is closing or that a hospital is going to transition to a freestanding medical facility, immediately has justified concerns about what that impact is going to be to the health of the community. And so it's important that not only the hospitals, but also state policymakers and candidly elected officials are all kind of on the same page about what the change in the payment model is seeking to do and what are the benefits of it, and maybe what things you might want to mitigate. So for instance, even if a certain service line is not utilized to the extent that you would expect, but is in a underserved type area, you might still make the decision to keep that one open because it's in the best interest of the community. And so there really needs to be a partnership, not only with the hospitals, but also with the state policymakers and others as you all proceed with this. So with that, I will pause and I will be more than happy to take any questions.
Great. Thank you, Patrick. That was fabulous. And thank you for the added perspective. So there are a handful of questions that have come in from the participants. So I'm going to share them, and we've only got about 15 minutes till 10 o'clock. We're going to need a couple minutes to wrap up. So Patrick and Bob, as appropriate, please address questions as succinctly as you can. So the first one, I think, Bob, is for you. And this question is, does the all-payer payment system require an increase in Medicaid payments? I assume that means an annual increase, or maybe not, maybe an increase at the beginning. And how does that work?
No, initially it doesn't require any sort of change in payment levels of individual payers other than the overall inflation applied to each of the payers. So it wouldn't require that Medicare or Medicaid increase what they pay and commercials decrease. Although over time, those payer differentials could be reduced by adjustments, small incremental adjustments. If the model generates savings for the public payers, then there's an argument that you might be able to increase Medicare, Medicaid payment, decrease commercial payment to reduce those differentials. But initially, and if the system chose not to do it, you wouldn't have to adjust those payment levels.
But it does require the annual inflation adjustments for all payers. Right?
Yeah, but that would be uniform across each payer, the same amount. But as I said, as a policy decision, you could decide to try to reduce those differentials over time, gradually.
Okay, thanks. Next question is, and I think this is for you too, Bob. The flexible global budget formula depends on the hospital definition of fixed versus variable costs. However, when volume changes dramatically, fixed costs such as the number of OR rooms or hospital beds becomes variable. How does the model account for the shift?
Well, this is kind of an averaging system, for better or for worse. And as Patrick said, there's a temptation to try to refine it, to make it specific to each hospital. Well, that unfortunately builds in a lot of complexity. The model I'm proposing actually was a model that was in Maryland, operated successfully from 1976 to 1990. And so overall, it worked well. It wasn't precise. But the problem with trying to make a regulatory system more precise for each individual hospital is you tend to build in complexity. So you'd have to pick fixed and variable costs that are more or less appropriate for the category of hospital that you're regulating, and then stick with it and not make adjustments over time. But you could vary it, for instance, for rural hospitals that have much higher proportions of fixed costs. You could go to an 80% fixed, 20% variable. But for most hospitals, you want to stay in that range of 50 to 60% variable moving forward, and just leave it at that.
Thanks, Bob. Patrick, here's a question for you. Can you tell us a little about specialists who often compete with the hospital or may be employed? How did alignment succeed and fail with them?
Sure. So I think that's an ongoing conversation. And the reason I say that is, for even the employed physicians, that you may make the assumption that there should be better alignment because they're employed by the hospital. One of the challenges is many of those specialists obviously want to grow their service line and grow the number of procedures if they're surgeons to do, obviously appropriately. But, many of them, particularly at the academic medical centers, they're coming there and they want to grow kind of premier type programs. And so there's a natural tension with the global budgets and then kind of the hospital leadership that's trying to manage under a global budget while at the same time building those high performing service lines. There have been some programs through the Care Redesign program that have launched in Maryland, which are basically modeled after the CMMI bundled payment programs. But so far the uptake there has been relatively low. And so I think there's a lot of opportunity here to still figure out how you better align with specialists.
Bob, anything you want to add?
No, I just think, over time, there is a possibility for hospitals to structure incentive payment programs with their physicians, both employed and specialists, as well as encourage payers to be involved and try to align the incentives in their payment mechanisms for physicians.
Okay, thanks. Bob, the next one's for you. Does this model anticipate a global hospital budget for Rhode Island? That is, all hospitals have responsibility for success of their individual budgets and for the global budget for the state.
Yeah, I think that's the goal of this. It certainly was the goal of Rochester. It's more kind of a collective community-based approach. But you have, as an individual hospital, some autonomy and flexibility in terms of how you reallocate resources. But everyone's sort of, pulling the oar in the same direction as a result of the incentives being more aligned both within the hospital, across the system, and with payers.
Okay. Next question is, how does the model tie in future quality performance? I'm especially interested in a hospital that has exceptional performance versus a system with poor performance.
When we started the fixed global budgets for the rural hospitals, we were concerned about that question specifically. So we also had been implementing a system of pay for performance around various quality measures. Of course, that's challenging because quality measures are not as good as they could be, but we implemented a readmission program, a hospital acquired conditions program, where you incentivize hospitals with incremental rewards or penalties based on their performance on a variety of these measures, including infection rates. ED wait times was another thing that was proposed as being involved in the pay for performance structure. So you'd have a supplemental program that would provide incremental rewards or penalties for hospitals based on metrics of the performance on these different quality dimensions.
Patrick, can you share your experience with how quality was built in
Sure.
to the global budget?
Sure. Yeah. No. And to Bob's point, I mean, many of the programs that are measuring kind of cost savings performance, so total cost of care programs and that sort of thing, there's always a quality kind of adjustment attached to it. So if you do a really great job saving money, but you do a really terrible job on quality, you're not really going to receive the financial benefit that you think you're going to do. And so you need to be performing well on quality programs in order to do well. And so even though there are, as Bob articulated, some kind of standalone, so to speak, programs that look at quality, the same results are also then tied back into the kind of more cost savings focused aspects of it. And so quality very much kind of ties into everything that's done. Similarly, on kind of the ACO side, for many of the programs that are out there, many of them will have kind of quality gates. And I know for the Maryland Primary Care Program, which was modeled off that CPC Plus, for instance, there was a quality threshold that the providers need to achieve. So even if, again, you did a great job reducing utilization, if you didn't perform reasonably well on quality, particularly patient satisfaction as well, you may not achieve any of the performance payments that you would normally receive.
Great,
One
thanks.
other point I noticed in the chat that there was a discussion about public reporting. I mean, that was something that I think has played a role and hopefully can play more of a role in the Maryland system, which is reporting on these various performance of hospitals on quality measures, but not only for the public to put pressure on hospitals to improve their performance, things like ED wait times, for instance, but also to get payers engaged. and to identify hospitals that are lower cost, higher quality, and then incentivize them to move patients to these higher value hospitals. And then under a flexible global budget program, the hospitals won't resist that type of outcome.
Thanks, Bob. Patrick, it's a question about how the pandemic has affected the Maryland model. Do you have a sense? I mean, obviously you're not at the University of Maryland medical system anymore, but do you have any sense of how Maryland and its hospitals have had to modify or respond to the pandemic?
Sure. So I would say one thing that has been helpful, and I don't mean to at all to minimize kind of the current strain that the hospitals are under or how challenging the past 2 years have been, but in some ways the global budgets and the fact that there was the HSCRC there allowed for kind of a smoothing a little bit of some of the disruptions that have occurred in other parts of the country, because the HSCRC through the global budgets was essentially able to maintain those global budgets even as volumes cratered, particularly in the spring and summer of 20. So the global budgets actually helped to stabilize the finances of the hospitals, at least initially. Now the hospitals now are experiencing the same strain as others nationally around staffing costs and other things like that. But particularly in the early stages, pre-federal stimulus money to the hospitals and others, the global budgets in Maryland actually did help to provide kind of a stabilizing force for the hospitals.
Any sense of how they're responding now to the workforce shortages and at least temporary spike in wages?
Yes, so so they are accessing some of the federal funds that are out there. They are trying to be creative, kind of out of their own pocket, candidly, in some instances. But part of the challenge is, for every hospital that then increases wages or provides some sort of retention bonus, the next hospital down the street kind of has to similarly match it. And then you have staffing agencies that kind of up the ante even further. I mean, there have been numerous staffing agency issues, which I'm sure you're well aware of. And so the challenge is it just kind of creates this ongoing price war to try to be able to maintain your staff, and it's challenging. And so the state of Maryland has done things like allowed retired nurses and others to come back into the workforce, trying to promote and graduate students earlier, allowing reciprocity with other states. So kind of any tool in the toolbox that can be used is being attempted. But staffing is a real challenge. When I look at the capacity at each of Maryland's hospitals through a separate engagement I have, it's challenging. And part of it is not only the patient volumes, but just the number of staff beds has greatly decreased because of all the staffing challenges.
Okay, so we are near the end of our hour and a half. I'd like to thank Bob, Patrick, and Deepti for just great presentations and a wonderful educational experience for all who've attended today. Patrick, you want to bring us to a close?
Sure, I'll just echo that thanks, especially to Deepti, Bob, and Patrick for sharing their extensive expertise. I certainly view this as the start of what will be, I know, a really robust conversation. I want to thank particularly the members of the Advanced VBP Subcommittee of the Rhode Healthcare Cost Trends Project who attended today, and who, as Michael said at the outset, were really the genesis behind having this educational webinar on this topic. So thanks to everyone for the continued interest in what I think is a really important model that I think continues to deserve really strong consideration. So thank you all very, very much. We'll look forward to having more conversation. And thank you, Michael, for facilitating us today. Thanks so much, all. Have a good day, and please stay safe, everyone.